Thank you. Well, once again, I'm Congressman Dr. Raul Ruiz. I represent California's 36th Congressional District in the United States House of Representatives. I'm an emergency physician, a public health expert, and I'm also chair of the Congressional Hispanic Caucus, and it is truly an honor to be part of UCR's inaugural, right? Diversity, Equity, and Inclusion Colloquium. So as the founding Senior Associate Dean of Community Engagement and Partnerships here at UCR School of Medicine, it always feels like home when I come on campus. And it feels like I'm back with the gang. So today we're here to discuss a topic that is essential to the health and well-being of our communities: diversity, equity, and inclusion. Those three words carry so much power and potential. And those three words also affect health outcomes. Those three words can move mountains and ensure that populations can have a better life. So for all of us in healthcare, they illustrate a future where your background, your zip code, and your income do not determine whether you have access to quality, affordable care. The fact that we're all here today to discuss this very topic gives me hope that the future is within our reach. And so let me just say that I'm incredibly excited to be here surrounded by people who share this vision, students, promotoras who want to join this fight, and faculty and staff who carry the banner of equity and social justice every day. That has been my life mission, and I have done everything in my studies, in my education, in my practice, under the banner of health and social justice. And in that, you need to understand health equity and disparities and understand what social justice is, which in my definition is the fair allocation of resources where they're needed. And that quite simply is the basic understanding of equity. Equity is not equal, right? An equal amount of resource for an affluent community and an underserved community does not have equity in its formula or definition. Equity is a simple public health term that states that the majority of the resources should go where the resources are needed most. It's a simple concept. You look at the risks and you address those risks. We practice equity in our management of chronic illnesses all the time, in making sure that we spend the resources in order to reduce the highest risk factors for illnesses in a patient or in a population in public health in order to have the best outcome possible, right? And so, for example, in the pandemic, we know that there are a higher risk for essential workers in underserved communities to get the disease, and they're at higher risk of spreading it to others. And so they're at higher risk of dying from COVID-19. So equity means making sure that we send our resources to the communities that are at highest risk. But too often, unfortunately, that doesn't happen. Too often, the resources go to where they are needed least, in very affluent areas. And so that's where the idea of equity comes from, and we need to really start focusing on it. And I care about this personally because I grew up in the barrios of Coachella. I saw myself a part of this work at a very young age to help others. My first home was a trailer in a trailer park. My parents were farm workers, and they worked day in and day out with calloused hands and tired backs with minimal rest to give us opportunities that they never had. And I remember the day when I said I was going to be a doctor. I was about 4 or 5 years old, and my mother asked me the question that all mothers ask their children: "Mijo, ¿qué quieres hacer cuando creces? What do you want to do when you grow up?" And my mother was the person who always volunteered in the community, who would give the shirt off her back to anybody who needed it, and give food to anybody who was hungry. And I admired that. And so when I asked her, I said, "Mom, well, what do you call people that help others like you?" She said, "A doctor." I said, "A doctor, mijo." So ever since I was 4, I had in my mind that I wanted to be a doctor so I can help people. And so she was smart that way. And so, you know, I graduated from Coachella Valley High School. I went to UCLA. I graduated with honors. I then went to Harvard Medical School. I did a joint degree program with the Harvard Kennedy School of Government. During that experience, as a medical student, I spent almost a year in the jungles of Chiapas, helping the very poor indigenous communities. I oftentimes would go with just my backpack, and I would hitchhike rides and do public health work, training promotores in the jungle on basic public health, and needed a Spanish translator, or we had to use a Mayan dialect translator because they also couldn't understand Spanish that well. So it was very underserved, extreme poverty level, basic public health service. Then I went to the Kennedy School after that experience. Oh, and by the way, in between there, I did 3 months at the CDC focusing on violence prevention with the National Medical Fellowship Program that take minority students from medical school to help train them in CDC work and violence prevention. From there, I went to the Kennedy School, finished my MD MPP, did a year of general surgery internship, did a year of emergency medicine research, and finished my emergency medicine residency training at the University of Pittsburgh. Went back to Harvard to do a fellowship in international emergency medicine, where I acquired my master's in public health and did consulting for the governments of Serbia and El Salvador before I came home to fulfill a promise. And the promise I made was to return home after I received my degree. Because as a first-generation college student, my parents didn't know how to pay for school. My older brother was the first to graduate from high school in the whole family. He went to Cal State San Bernardino. And when it was my turn, I remember the day my mother came to me and said, "Son, you know, your dad's having a difficult time." She kind of lowered, tried to say, "Oh, it's going to be hard to send 2 boys to college." And I was like, "Oh no, I have to go to college because I'm going to be a doctor and I need to go to pre-med and I go to medical school and all that." And so I went to my dad's room and he was watching the Yankees play, to my chagrin. He was a Yankees fan. And he was chewing sunflower seeds, and I said, "Dad, Mom just told me that you're concerned about how you're going to pay for my college." I said, "I want you to know I have a plan." Right? Then he piques his interest. Because at the time I was sweeping floors at the packing house earning minimum wage. I said, "I'm going to help you." And he's like, "How the hell are you going to help me?" I said, "I have an idea." So I put on the one suit I owned at the time. It was a god-awful itchy blue suit. And it fit too large. It was 2 sizes larger because I thought I was going to grow into, but nobody told me at 17 I wasn't going to grow much anymore. So it fit awkward. I borrowed a briefcase so I can look as professional as possible. I wrote out a contract. I typed it out because at our school we didn't have computers yet. And I made copies and I went business to business. I'd pull out my contract, and it was 110, 115 in the summer in Coachella, and I'd walk into mom and pop shops and I'd hand them my contract and I'm saying, "I'm offering you an opportunity to invest in your community by investing in my education. Because I promise you, I will be a doctor and I will come home and serve the community." And so they gave me $50 and $100 here and there, and I raised like $2,000 I paid for my school books at that time. It was crowdsourcing before they even invented the term. Right? And so 17 years later, after I left home as a 17-year-old, I came back and practiced emergency medicine at Eisenhower's hospital and started doing a lot of the community projects and the community advocacy that led me to UCR School of Medicine. And so I made it my mission to improve the community's access to quality, affordable health care. I knew then that hope without strategy is just hope, and that a vision without implementation is just a vision. And so wanting to implement my vision of health equity and social justice and diversity and inclusion, I rolled up my sleeves and got to work, because diversity, equity, and inclusion doesn't just happen. You need sweat equity. You need to proactively institute the solutions and the resources and the staff and go out and create what we want to create. We cannot rely on a system that has left so many out to begin with and expect it to produce different results. So I strived to not only create opportunity and strategic plans, but also to implement them. I began working as a physician in farm worker trailer parks, providing free health education after they came home from the fields. I worked a lot with promotoras in the area. We actually led flu vaccination campaigns after the H1N1 pandemic back then. And that is what we utilized for this COVID pandemic. So when I was speaking to Vice President Pence at the time and the current administration, I knew what I was talking about, what we needed to get done to really reach the underserved communities. So I organized those free flu vaccine campaigns, targeted our most vulnerable seniors. I helped start a free clinic with the organization Coachella Valley Volunteers in Medicine to help our community's most vulnerable and underserved access healthcare services they would otherwise not have. And together with my girlfriend then, now wife, Monica, I founded the Coachella Valley Healthcare Initiative and started the Future Physician Leaders Program to address health disparities that plagued our communities and build a strong pipeline of local providers to address the shortage in our area. Again, it doesn't naturally happen. There's too many systemic barriers for us to dream of a world of inclusion and equity and diversity. You have to take the initiative, plan, and execute. And sometimes you have to execute without the funding, and the funding will catch up simply because it's the right thing to do, right? And so we got to work and created these programs with no funding, no budget, no staff, out of a 2-bedroom apartment, and some of my speaking fees went towards all of the work that we did. In the emergency department and in the community, I saw the face of failed policies, and guess what? It wasn't smiling. I saw the human story behind the numbers of a budget spreadsheet that favored the affluent and hurt working families. I saw seniors, literally saw seniors pillaging trash after a promotora workshop in gathering information about healthcare in Mecca, in the Mecca church, seniors pillaging trash. And I'd come over, I said, what are you doing? Oh, doctor, I'm collecting these cans to pay for my insulin because I don't have enough money. But doctor, don't worry, I only take half my dose so that I can make it last. And those in the healthcare profession know that half a dose is no dose at all. It's just the improper treatment, and there's very little benefit long term for that. So this is a result of systemic and institutionalized barriers that has produced obstacles for equity, diversity, and inclusion. And these are the challenges that we take upon ourselves to identify, to change, to resolve in order to promote equity, diversity, and inclusion. And so that's what motivated me to be a doctor, right? That's what motivated me to actually run for office. And that's what motivates me every single day when I'm walking in the halls of Congress advocating for our communities. So my perspective as a physician really is the most important thing I bring to public service. So every day I work to find a diagnosis. In other words, policy should be about solving problems. And if you can't define the problem, then what are you solving? And so that's why the research component is very key in good policy. The first question I ask my staff in DC when they talk about a certain bill that either I'm going to be decide to vote on, or whether I need a co-sponsor, is what does the author of this solution think the problem is? And you got to start at that basis to really identify, is this the right solution? Does this solution actually address that problem? Or is this just makeup on a gruesome issue to just try to get another headline and increase their popularity? So do the diagnostic workup, define the problem, then you come up with a solution or the treatment modality. And then as a physician, we take it another step to implement the therapeutic modality and then measure the outcome that that therapy had and change course if we need to. It's also a public health model that we do, but policy unfortunately ends for policymakers at the passing a law and then moving on. And we need to do a better job at evaluating the effects of that policy in the public to determine its effectiveness so that we can improve upon them in the future. Now, that's not for everything, because clearly the Affordable Care Act, for example, reduced the amount of uninsured, and so we have those numbers and other things that can prove that life has been better for millions of individuals, but there's the implementation part that happens within the administration that can be improved on a lot of different programs, whether you're Democratic administration or Republican administration, because government should work for the people and not vice versa. Government should always strive to improve its effectiveness and its efficiency to help the people in the services, in the innovation, in the aspirations of the human potential within our country. And quite honestly, for those of us in global health, work around the globe, right? And so when I founded the Coachella Valley Healthcare Initiative, we diagnose our community provider shortages and the cost of care as the most pressing challenges we faced when it came to healthcare access. Essentially, those students in my Future Physician Leaders program did the research to back up the information that the promotoras, the students, the community members informed us during our community forums and stakeholders. The number one issue was cost, not just the cost of care, but the resources needed for the FQHCs and the community health projects to continue to provide the services for the community. The second biggest barrier was the lack of infrastructure. What I mean by that is we literally counted full-time equivalent physician providers in the underserved areas and how many exam rooms, we did a safety net mapping, including emergency rooms. And we counted that there was one full-time equivalent per 9,000 residents in the eastern Coachella Valley. And it was similar in Desert Hot Springs, the two medically underserved areas designated by the federal government. We also identified that there was one exam room or emergency room for a catchment area for 150,000 folks in terms of population. And so we were severely underserved in terms of the amount of providers as well as space, clinics to see the patients. And to give you a sense, the criteria or the recommendation is to have one physician per 2,000, and to be designated medically underserved is 1 to 3,600, and we were at 1 to 9,000. So that was an impetus for a lot of grant writing and a lot more strategy development in the area. So those statistics are only going to get worse because the rate of producing providers is not equivalent to the rate of growth of our population. And so that's why the UCR School of Medicine is so important. That's why advocating for GME and programs and nursing and public health and everything that we can do to foster more providers and support ancillary staff, et cetera, to do this work is crucial. The Association of American Medical Colleges projected that by 2034, we will experience a shortage between 7,800 and 50,000 primary care physicians nationwide. And it takes a long time to create a provider, right? To help train a provider, 4 to 8 years sometimes. So I can only imagine what that looks like for rural areas. And so based on this evidence, I'm working on policy solutions that take a public health approach and prioritize equity, diversity, and inclusion to improve access to care. So we know that when physicians train in underserved areas, the data's there. If you train, first of all, there's two predictors of where a physician will train, end up. One is where they're from, where mom and dad is from and all their relatives are from. And two, where they last trained. So that's why the FPL program was so important. Because if you go into the underserved communities, create a pipeline, spark their interest, actively inspiring them to want to do this work, create a venue for them to go to undergrad, then medical school, then train them in those communities, then they are more likely to stay in those communities. And the teaching health centers are a program within the FQHCs that by definition need to see the underserved populations on the Medicaid program, Medicare, or that are underinsured or uninsured. And so if you augment this program, they are more likely, and studies have shown that there's an 80 to 90% predictability that they will stay in those communities. So as Dean D said, we increased the funding for those teaching health centers, and we've been working and advocating to create more GME slots throughout our nation. And in particular, my bipartisan bill, the Physician Shortage GME Cap Flex Act, would help address the crisis while also improving access to care for our most vulnerable communities. So instead of 5 years, it would increase to 10 years a rural hospital's ability to create the full gamut of specialties that they need for training. And that's very important. That would also keep it into statute, in other words, make it law. So we're making real progress in this front. Thank goodness we have an administration that understands equity and that has institutionalized it within their laws. In fact, they have a Justice 40 initiative that within the bipartisan infrastructure law, the American Rescue Plan, 40% of resources need to go into underserved areas that need them the most. So, it's not the majority resource, but it's definitely different, and it's a big, big plus, and it's codified into law. And that's where all of you, whether you're students, whether you're staff, whether you're faculty, whether you're in training, whether you have hopes and aspirations to change the world, or whether you dream to make sure that there's more women in your positions, or you want to have a pipeline of individuals from your communities to come and serve in a different capacity, then this is why we need all of you to continue your interest in diversity, equity, and inclusion, and it doesn't just happen. As chair of the CHC, I've created a strategic plan. We've reorganized our institution. We have now a vice chair of diversity and inclusion. We have partnered with the Congressional Hispanic Caucus Institute as our pipeline programs to develop staff, and we have instituted through laws and funding reports on how the Congress, the committees, and others are doing in the issue of diversity and inclusion in Congress. So thank you, and I'll take some questions.
We can do better than that. Let's give Dr. Ruiz. Hey, was everybody fervently writing down their questions? Yes? Can you pass them this way? Don't be shy. Come on. So we have some good ones. The first one is, what recommendations would you give a pre-med student who is seeking public office?
Oh, interesting. Like while they're pre-med?
Yes.
While they're pre-med. Look, I think that I'll give you the advice that my sage 4'11" grandmother who raised 9 children in poverty, who was very wise in her ways, told me. And that's, focus on your studies first, son. right? Because if you run for office and it's a distraction, then you won't, there's a risk that you won't be able to fulfill your dream of becoming a doctor. Now, there have been some medical students that would run for office and others, but it all depends. Like, I would have to sit down with you and say, are your grades okay? Are you going to go to medical school? Because if you're pre-med, you want to go to medical school, and being pre-med is not that easy. And because there's less and less slots available for the demand, I would say, I would have to counsel you as an individual. Who asked that question, by the way? You? I would have to sit down with you and say, okay, what's your scenario? Where are you in school? How are your grades? What does elected office mean? And then see if this is, if maybe you have the time to do it. Now, if you're asking what should we be doing if we want to run for office eventually, then I would say yes, 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 and yes, because we need more physicians, providers to know how to create policy, how to create laws and funding in order to help the initiatives. We need people that can speak both languages, the language of science and public health and politics and policy, in order to take the science and know how to advocate for it in order to improve the lives of the people we want. And by the way, that has been a common theme throughout my day in speaking with the public policy school and some folks at the science to policy programs and all this, is that we need to do a better job of moving from the research bench or the field research into policy advocacy, and how to take what we learn and actually implement it at a larger scale. Not just in a nonprofit, not just in a community project, but in the tune of millions of dollars of resources, new practices that help improve the human experience. And I'm in the old-fashioned belief that science, the end goal of all science, is to enlighten ourselves to improve humanity and our experience on this earth, and to really help humans reach and nature and animals reach our full harmonious potential. We can't do that when we have extreme poverty and inequalities and disparities. So that's an important issue. That's why I like social justice. Okay?
Hey, Dr. Ruiz, everyone is very, very interested in your role as a physician as well as a policymaker. So someone asked, going through medicine and moving into policy work, what advice would you give a medical student who wants to incorporate policy and advocacy in their career? And are there lessons learned that you've acquired along your journey?
Yes, so one is do an internship or a fellowship in my office. The invitation is there. Two is get involved, right? Too often, like me, I'll tell you, like me, I was so focused in understanding the Krebs cycle. I was so focused in getting the grade for that block. I was so focused in making sure that I did what I needed to move to the next step, even though I was a student activist or a leader or did a lot of things in the community, that I didn't fully appreciate what it meant to what policy was or what the role policy had. It wasn't until I was in medical school when I went to the Kennedy School of Government to get my master's in public policy that I was like, wow, this is really great. Now I can apply all of these skills in what I do. So one is join your leadership advocacy groups from your AMSA, American Medical Students Association. Two is get involved in your local community group, nonprofit advocacy groups. Three is, if there's a particular policymaker that inspires you, that you like, then, understand politics, understand what motivates that person. Get involved in their campaigns or do their internships and fellowships try to get it placed in their offices so that you can get that experience to understand the language and do the work.
Okay.
And, oh, sorry, one other thing. It's not just about politicians either. There's a lot of think tanks that are out there that you do the research, you do the advocacy, and you can go out and apply the research into the community.
So thank you for your advocacy on behalf of the Dreamer undocumented college students. During these challenging times with DACA, what is your hope with the strategy approach, given barriers to legislative solutions and given the community health implications of allowing Dreamers talents to flourish in workforce and educational settings?
Okay, so that's a very interesting question, because I'm as chair of the CHC, I helped devise our Congressional Hispanic Caucus strategy around the DACA and Dreamers, and we took an all of the above, any which way approach to helping improve and give security to Dreamers and the DACA program, etc. So the first approach was to pass the Dream and Promise Act. And we were able to do that within the first 3 months. In fact, we advocated for us to go back into session. So we actually changed the congressional calendar to ensure that we passed the Dream and Promise Act, and also the Farm Workforce Modernization Act, which would create a pathway to citizenship for farm workers and their families. And many of their children are Dreamers. And so that passed with bipartisan support out of the House. But as you know, we need 10 Senate Republicans, and they're hard to come by to agree that Dreamers should stay and have the full opportunities that everybody else has, and to contribute to our communities in our country and to provide them a pathway to citizenship. So the second step was through budget reconciliation to figure out a way how we can create a pathway to citizenship for as many people as we can. Unfortunately, under the rules of the reconciliation, the parliamentarian 3 times said no. At that point, we said, let's do it anyway. And unfortunately, they couldn't get the Senate couldn't come together and get a reconciliation package through the Senate the first time. The second time, just recently, they did the Inflation Reduction Act, which has a lot of good stuff, but it didn't have any immigration issues there. So the third phase of our overall strategy was to work with the administration. And so far, I've led 2 sessions, briefings with the president, and we research our asks and what we were going to advocate for in the Oval Office, and advocating to strengthen and empower the DACA program and to help our Dreamers has been a consistent advocacy that we've had, including student loan forgiveness, which, yay, the president did. All right, you're welcome. And strengthening DACA has been a major priority. So, as you know, we have some cases up in the judicial system that could decide that said that the previous administration didn't provide a rule and time enough to debate that rule to formulate this DACA executive order policy program. So the administration just, when was it, like 3 days ago, Secretary Mayorkas, the Secretary of DHS, called me on the phone and said that they're putting out their rule. And I said, are you expanding it? Because that's what we want. We want to strengthen, we want to expand it. We want to also provide, have Dreamers be eligible for Affordable Care Act subsidies and Medicaid and all these other programs. And they said no, because of this court case, that first they're going to go through this process, and after the rule is done and complete, and we win, I knock on wood, we win, and DACA is still in effect, then they will do another rule to help strengthen and expand it. And so I said, vale más, you better, because we'll come after you. And so that's the latest for Dreamers and DACA. And in addition, we have instituted in the last appropriations House legislative branch funding the ability for Dreamers to work in Congress. So that's one. It passed out of the House, so we want to make sure that it stays in the overall funding bill. And so we continue to expand the capacity for Dreamers to work, in this level.
Thank you. So with more individuals being covered with health insurance, how do we provide equitable and quality care within underserved regions?
Wow, that is the biggest lesson learned during the pandemic, that I was talking to D&Ds, that we knew this, right? We know how to do this work. The pandemic made or brought awareness to the problem that a solution that we have already known can now be applied for the long term. And so one of the key lessons is that you cannot rely on a healthcare delivery system that has produced these disparities to begin with, to then expect it somehow to utilize that system to try to deliver healthcare to reduce the disparities that exist. What do I mean by that? I mean that the way healthcare is delivered in our country leaves out the most vulnerable populations. Okay? Historically, we've talked about, okay, we just need more black and brown and underserved people working to address equity issues. And there has been great amount of progress in ensuring that people care, people provide services in underserved areas, rural areas in a very culturally sensitive, appropriate, and effective way. But we're missing a key component, is that patients still have to go to the hospital. Patients still have to be able to navigate the system. Patients still has to have a level of education to have health literacy so that they can advocate for themselves. Patients still have to have online services to navigate, to set up the appointments, and to get the care that they need. And our system is not set up that way. Our system favors those who live in a more affluent, resource available capacity to be able to navigate and seek out and search that information. So, what did we learn in the pandemic? That the best way to reach the hardest hit, the biggest need, is to incorporate a community-based model, working with heroes that are here, the promotoras, who understand the community, who care about the community, who know how to mobilize the community, and the community trusts them, partnering with organizations and with the resources that are necessary, and going into the community and taking the care to the people. That's the biggest lesson learned. That's the biggest systemic change that we need to do. We're not doing that. And I'm talking primary care. I'm talking diabetes education. I'm talking about holistic physical therapy. I'm talking about basic necessities, even clean water. We have people in mobile home parks in the Coachella Valley that are drinking arsenic in their water. We have people that don't have good sewage systems or sanitation with trash. And that's a public health risk in our country. And so, being able to integrate academia and training and practice with local community support, partnering to take care to the people, is key. And one of the ways that we're doing, and I'm researching and I'm developing policy to help pave this path, is to incorporate your phones, your iPads, your whatnot, incorporate certification programs for promotoras in the community, to convert it into a paid program. So it's not just volunteer-based or a measly stipend from an underserved, under-resourced nonprofit, but that it would be a certified program with it's a career that people may want to take, and they can join. And then once you do that and incorporate the technology with them going into the homes to communicate with other providers, to do health coaching, to do maintenance and capacity building in community, that's how you're going to change healthcare outcomes in a community.
Okay, so
I'm passionate about that.
No, I love it.
I'm passionate about
Public health, you're speaking. You talked about bringing, having our promotoras and our community health workers go into homes with devices, right? To be able to take care of the needs of the community. So this question is about the digital divide. So making telehealth a reality for the underserved in inland California, how do you see legislation play a role to prevent the underserved from gaining access to digital health?
How do I see legislation that prevents the underserved from, or how do I?
It says prevent, but I think since the underserved do not receive access to, well, they may not have access to Wi-Fi,
Okay.
Technology, so they're limited, right? We're doing telehealth. A lot of telehealth was done during the pandemic, and a lot of people weren't able to access healthcare because of that.
So there's telehealth, and then there's what I call tech medicine, or I don't know if this is the digital health that people are referring to, but telehealth is a system where you got to go to a provider. There's somebody there who facilitates an exam. There's a provider on the other side who looks at the equipment. You can, look into the ear with the person doing the exam, and then there's a consultation, and then there's a diagnosis and a treatment plan, etc. During the pandemic, we have facilitated more reimbursement. We have increased the services that can be provided. We've looked at some interstate barriers to fix, and we're also looking at some of the barriers for these exams to be done in the community so that people don't have to go to a healthcare facility, et cetera. So that's one thing. And there is legislation that would continue these upgrade telemedicine policies till 2025. We just voted one out of the House, and there's other fixes that we can facilitate it more. The other issue is tech medicine, and that is an issue that's booming. There's apps that say that you can speak to a psychologist. There's apps that say if you have some kind of dysfunction in your reproductive tract, then they can hook you up with medication. There's other apps that that are promoting these type of medicine, and there's some big groups like Google and Amazon and others that are trying to move in that direction. It is naturally going to happen. We need to catch up in the policy to protect the legitimacy and the privacy and all the other stuff, and to make sure that consumers are protected in that aspect. But that is a key path in home care, in the community care that I talked about, because when you need to make a decision between, buying a computer or, other goods, a smartphone is one of the most efficient and effective ways that an underserved family can be connected and can increase their chances of getting the information, knowledge, communication that they need, right? Because it's a little computer and it serves multiple purposes. So when you hear, oh, but look, they got an iPhone, shut up. Their iPhone is their gateway to society, and their one tool that they can use to help their family, get a job, identify resources, etc. And if you're going to invest in something in a poor community, right, in terms of a technology device, it would be a smartphone. And that is a capacity for us to be able to communicate and do public health education, to gather information, and to do training. Now, one of the things that we have to focus on as well is the deployment of broadband, high-speed broadband. The bipartisan infrastructure law, the American Rescue Plan, and now the Inflation Reduction Act has a lot of investment to move broadband, and with the Justice 40 initiative, 40% of it needs to go into underserved rural areas. And one of my bills that got signed into law, I think in the CARES Act, was to have tribal governments be a criteria for priority of when the decision is being made, because that serves a dual purpose. One is tribal communities are very underserved, rural tribal communities, and two is they're often around neighboring rural underserved communities. So if you're able to lay the broadband down to reach an area, then you can expand from that area into other communities. And then you really expand broadband and internet into those areas.
So I have to say, I'm only allowed to ask one more question. I want to tell you all, I'm reading them. You have some phenomenal questions, so please don't be upset with me that I didn't get to your question. But this one I have to ask. So since you're from Coachella Valley, you grew up and were raised here, and you went off to Harvard and got your medical degree in public policy and public health degrees, and you decided to come back and return to your community. How can we encourage other health professionals, especially medical doctors and researchers, to serve and practice here in rural areas or from the communities that they're from?
You know, it starts with a dream. And I think those of us who have the capacity to foster dreams in young minds and inspire them to find their purpose, we need to do that. We need to do more in mentoring. We need to do more in making ourselves available in the community. We need to inspire people to dream. And you need to go into those underserved communities. You need to have conversations and communities and roundtables. You need to be present with them and understand that. So that way, when you inspire them, you plant a seed. And sometimes all it takes is that one individual who said, I believe in you. You can do this too. And sometimes it takes a student to see somebody who is like them in that position to say, I can do that too, right? And so you start there. Develop your pipelines. Don't let them leave. Stick with them. Provide the equity work, right? Your resources, your effort into helping mentor students along the way, and then they'll get there. And you have to be a role model, right? And I think that if you're already in academia, if you're already at work, man, get out of your silo. Get out of your chiefdom in your area. Because then, you know, it's all about your research and publishing and getting grant funding, and you're in this silo amongst your peers, and you know there's a friendly competition to see who can publish more and whatnot. Get out of that. Go into the community, like Dr. Cheney. Go into trailer parks. Figure out, volunteer, understand how your research can help improve the lives of the people that your research is intended to improve. Find the human face for the research that you're doing, and then have that face of that person and community front and center every time you go to your bench, your lab bench. Have that human face in front so that it motivates you to take your data into advocacy to change policy and funding to bring in resources and create the projects in a larger scale. Larger meaning instead of just a nonprofit or a program, but institutionalize it so that you can elevate the human potential with your science. But it takes a story and it takes a face. It takes a human element to this. And that is where oftentimes we need to leave the silo and go out and be with the community. Thank you.